The management of invasive breast cancer, a multidisciplinary approach for improved outcomes. Welcome to today's discussion on the management of invasive breast cancer, where we explore the latest multidisciplinary strategies shaping clinical practice today. This episode will guide you through the journey from diagnosis to survivorship, highlighting the importance of personalized care for every patient. Introduction: The treatment of invasive breast cancer represents a paradigm shift in medicine. No longer is it a one-size-fits-all disease. Instead, each individual's care plan is tailored according to the unique characteristics of their tumor, the stage of the disease, and patient-specific factors such as age, menopausal status, existing health conditions, and personal preferences. Central to this approach is a team of experts, including surgical oncologists, medical oncologists, radiation oncologists, radiologists, pathologists, and nurse specialists. The main objectives guiding breast cancer management are to achieve cure, especially in early-stage disease, to control local disease and prevent recurrence, to avert the spread of cancer to other organs, and, in cases where the cancer has spread widely, to alleviate symptoms and prolong life. The cornerstone of management: multidisciplinary evaluation before initiating any treatment. A thorough evaluation is essential. Pathology and biomarker analysis provide the foundation for all decision-making. The histologic type, with invasive ductal carcinoma being the most common, is identified. The tumor grade reveals how abnormal the cells appear, ranging from grade 1 to grade 3. Hormone receptor status, including estrogen and progesterone receptors, determines whether the cancer is fueled by hormones. The status of the human epidermal growth factor receptor 2 is also assessed, as a positive result indicates a more aggressive but now highly treatable form. The proliferation rate, measured by the Ki-67 index, shows how rapidly the cancer cells are dividing. These factors combine to define the major molecular subtypes, which dictate the choice of systemic therapy. The luminal A subtype, characterized by positive hormone receptors and a negative human epidermal growth factor receptor 2 result with a low proliferation rate, generally has the best prognosis and is highly sensitive to endocrine therapy. Luminal B tumors have a higher proliferation rate or are positive for both hormone receptors and human epidermal growth factor receptor 2, making them more aggressive than luminal A. Human epidermal growth factor receptor 2 positive breast cancers, whether they express hormone receptors or not, were once considered aggressive but now have excellent outcomes due to targeted therapies. Triple-negative breast cancers, which lack hormone and human epidermal growth factor receptor 2 expression, are aggressive but often respond well to chemotherapy. Staging is performed using the tumor, node, and metastasis system, which evaluates the size and extent of the primary tumor, involvement of lymph nodes, and the presence of cancer in distant organs. Treatment modalities: the toolkit management involves a combination of local and systemic therapies, each targeting different aspects of the disease. Local therapy, targeting the breast and nearby lymph node. Surgery is often the first step. Breast-conserving surgery, or lumpectomy, removes the tumor along with a margin of healthy tissue and is typically followed by radiation therapy. It is the standard of care for most early-stage cancers and has survival rates equivalent to complete breast removal, also known as mastectomy. Mastectomy may be chosen for larger tumors, multicentric disease, patient preference, or when radiation is not an option. Oncoplastic surgery blends cancer removal with reconstructive techniques for better cosmetic outcomes. Assessment of lymph node involvement is also crucial. Sentinel lymph node biopsy is the standard for evaluating the axillary nodes, as only the first few nodes are removed and examined. If these are negative, no further node surgery is required. Axillary lymph node dissection, involving the removal of most axillary nodes, is now reserved for cases with extensive involvement. Radiation therapy uses high-energy beams to destroy cancer cells in a targeted area. It is almost always used after breast-conserving surgery and may follow mastectomy in cases involving large tumors, positive margins, or lymph node involvement. Advances in techniques have enhanced precision, minimizing side effects. Systemic therapy, treating cancer throughout the body. Systemic therapy is selected according to the cancer subtype and risk of recurrence. Chemotherapy employs drugs to destroy rapidly dividing cells. It can be administered before surgery to shrink large tumors and assess sensitivity, or after surgery to eliminate microscopic metastatic disease and reduce the risk of recurrence. Common regimens include anthracyclines and taxanes. particularly beneficial for aggressive subtypes such as triple-negative, human epidermal growth factor receptor 2 positive, and high-risk luminal B cancers. Endocrine therapy is used for hormone receptor positive cancers, which account for the majority of cases. It works by blocking the effects of estrogen or reducing its levels. Tamoxifen blocks estrogen receptors and is used in both pre- and postmenopausal women. Aromatase inhibitors, such as letrozole, anastrozole, and exemestane, lower estrogen levels in postmenopausal women. Ovarian suppression may be considered in high-risk premenopausal women and is often combined with other endocrine treatments. Treatment usually lasts between 5 and 10 years. Targeted therapy involves drugs that specifically target molecular pathways driving cancer growth. For human epidermal growth factor receptor 2 positive cancers, medications such as trastuzumab, pertuzumab, and adutrastuzumab emtansine have transformed outcomes. In advanced or metastatic hormone receptor positive disease, inhibitors of cyclin-dependent kinases are used in combination with endocrine therapy. For patients with human epidermal growth factor receptor 2 negative metastatic breast cancer and a BRCA mutation, poly-ADP ribose polymerase inhibitors may be effective. Immunotherapy, such as pembrolizumab, is now approved in combination with chemotherapy for high-risk early-stage and metastatic triple-negative breast cancer, helping the immune system recognize and attack cancer cells. Putting it all together, stage and subtype-based approach for early-stage, low-risk luminal A breast cancers, breast-conserving surgery or mastectomy, often accompanied by radiation therapy and sentinel lymph node biopsy, is typically followed by endocrine therapy for 5 to 10 years. Chemotherapy is often not necessary, and genomic assays may be used to make individualized decisions. Early stage, high-risk luminal B or human epidermal growth factor receptor 2 negative cancers usually require chemotherapy followed by endocrine therapy. Human epidermal growth factor receptor 2 positive cancers in early stages are treated with chemotherapy and anti-human epidermal growth factor receptor 2 therapy, which may be given before or after surgery. Early-stage triple-negative cancers often receive chemotherapy, frequently before surgery, and immunotherapy may be added for those at higher risk. Locally advanced, or stage 3, breast cancers often begin with systemic therapy to shrink the tumor before surgery. This is usually followed by mastectomy, radiation therapy, and more extensive lymph node removal. The choice of systemic therapy is driven by the cancer subtype and may include aggressive chemotherapy, targeted therapy, or immunotherapy. For metastatic, or stage 4, breast cancer, treatment aims to control symptoms and improve quality of life. Radiation therapy or surgery may be used to relieve pain or control bleeding. While cure is not possible, the disease is highly treatable. In hormone receptor positive cases, endocrine therapy combined with cyclin-dependent kinase inhibitors is preferred. Human epidermal growth factor receptor 2 positive cases continue to receive targeted therapy alongside other treatments. Triple-negative cases may be treated with chemotherapy, immunotherapy if the programmed death ligand 1 marker is present, or poly-ADP ribose polymerase inhibitors in those with BRCA mutations. Special considerations and survivorship. Special considerations include fertility preservation, which should be discussed with younger women prior to chemotherapy. Genetic testing is recommended for those with a strong family history or specific tumor types, such as triple-negative breast cancer diagnosed before age 60, to identify BRCA mutations. Reconstruction can be performed at the time of mastectomy or delayed until later. Supportive care for side effects such as lymphedema, neuropathy, and menopausal symptoms is essential. Survivorship care plans ensure that, after active treatment, patients receive ongoing surveillance with regular examinations and imaging to monitor for recurrence, manage long-term side effects, and promote overall health. Conclusion: the management of invasive breast cancer has evolved dramatically, moving from a primarily surgical approach to a complex, integrated model of care. By harnessing detailed insights into tumor biology and leveraging a multidisciplinary team, treatment is now highly individualized. This evolution has led to significantly improved survival rates and quality of life for patients across all stages and subtypes. Thank you for joining us on this comprehensive exploration of modern breast cancer management. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the Extraordinary.